Can you see my shared screen?
Yes.
Yes, we can see.
Yes. Okay.
Yes.
Okay. Hello everyone.
Yeah, just a moment. I'll introduce you and the meeting. Distinguished guests, distinguished friends, distinguished colleagues, good afternoon, good morning, and good evening to everybody from all over the world. Welcome to the Asian Heart Society's Cardiovascular Surgery Council's webinar. Today, our webinar is on future of coronary surgery, CABG and BlTA strategies in 2025. I will chair this session together with my distinguished friend from India, Professor Yugal Mishra, and Dr. Zheng from Beijing will join us later on. We have an extremely distinguished faculty. Let me introduce them. Professor David Taggart, who is a very well-known coronary surgeon and scientist all over the world, and Professor Dr. Tong Ding from Beijing, who is an expert in multi-vessel mixed coronary bypass surgery, and Dr. Kiser from Canada also will be with us soon. Dr. Gao from Beijing will be one of our faculty member. And last but not least, Professor Kukuchi Keita, who is one of the pioneers in the world in minimally invasive coronary surgery, will be with us sharing his experience. We will have a very distinguished panelist colleagues as well. Professor Vadim Popov from Moscow Vishnevsky Institute will be with us. From Lebanon, George Teddy will be with us, and also Professor Koray Ak from Marmara University in Istanbul, and Professor Ahmet Özkara from Liv Hospital, Istanbul, will be with us as giving you some burning questions. So let me start with Dr. Tong Ding from Beijing. He will share his experience on minimally invasive coronary bypass surgery for multi-vessel coronary disease as a single central experience. Dr. Ding, please.
Okay. Thank you. Hello everyone. Thanks for having me in the webinar to present our experience of mixed CABG. I'm Ding Tong from Peking University Third Hospital. Before my presentation, please allow me to introduce our department. With our leader of Professor Lin, recent years we have done many achievements. We have performed about 500 cases of mixed CABG, and almost about 1,300 multi-vessel mixed CABG. So welcome to contact us for academic communication. This is my disclosure. As we all know, the mixed CABG have many inherent advantages, such as minimal invasiveness and sternum sparing, and without cardiopulmonary bypass. But there are still two significant questions you need to address. The first one is whether the mixed CABG could sacrifice the mid or long-term outcomes, which is due to the incomplete revascularization, the poor graft PTC, or the MIS. Another question is whether the mixed CABG could strengthen the short-term benefit. So to answer the first question, we have done a research to about evaluation the midterm outcomes of mixed cabbage. The study is a retrospective study, and we have published this work. During 2015 to 2019, we have enrolled about 448 patients. And the primary outcomes is completeness of revascularization and graft patency and the 5-year MIS. This table shows that the baseline variables are comparable between the two groups. This table shows that the mixed cabbage, the completeness of revascularization is 95.5%, and the off-pump is 96.3%. The result is similar between the two groups. This is the post-operative outcomes. As for the mortality, myocardial infarction, stroke, and re-exploration between the two groups are similar. And noticeably, the mixed cabbage produced reduced transfusion rate. In our early stage practice, we introduced the post-procedural angiography to evaluate the graft patency, and the purpose is for the quality of control. As you can see, this table, the overall graft patency in the mixed cabbage is 96.2%, which is a comparable satisfied result. Up to 5 years follow-up, the cumulative death and MIS between the two groups is comparable. As you can see, the right figure, the mixed cabbage, the MIS rate is 19.9%, and the off pump is 22.1%. So we can conclude that the mixed cabbage could yield similar completeness of revascularization to the off pump, and could provide satisfied post-procedural graft patency. Besides, the mixed cabbage could also provide similar intermediate term MIS to the sternotomy cabbage. The mixed cabbage might emerge as a promising alternative to the sternotomy cabbage for select patients with multivessel disease. To answer the second question, whether mixed cabbage could strengthen the short-term benefits, we conduct another study. The study is a prospective pilot study, which has been registered in the clinical trials. The study is prepared for our future single-center mixed cabbage PRPP trial. This is study design and patient selection. During 2020 to 2022, we have enrolled 240 patients into the study. Separately, 120 in the mixed cabbage and 120 in the off-pump group. The endpoint of this study, the primary endpoint is 7-day and 30-day physical component summary, evaluated by a 36-item short-form health survey, and the 12-month Seattle Angina questionnaire. The secondary endpoint is postoperative outcomes, and the number of grafts and angiographic patency. The baseline between the two groups are comparable. This is postoperative outcomes. We can see the mixed cabbage could significantly reduce the transfusion rate. In our center, the transfusion rate is 7.5%. Besides, the mixed cabbage could also shorten the mechanical ventilation time, ICU stays, and the post-operative hospital stay. And the death, stroke, and the reoperation rate between the two groups is similar. We also performed the procedural angiographic for the two groups. The off-pump group, the angiographic patency is 96.4%, and the mixed cabbage at 97.1%, which is similar. As for the number of grafts, the two groups are comparable. We use the two method to evaluate the quality of life. The first one is the short form score. The short form score is a health related recovery questionnaire after surgery, which could primarily reflect the early stage recovery. And the short form score is divided into PCS score and MCS score. The PCS score is primarily reflect the physical status, and the mental and the MCS score is primarily reflect the mental status. So as shown in this figure, the 7-day and 30-day PCS score in the mixed cabbage is presented is favorable than the off-pump group. So the result is consistent with the other post-operative results, such as the shorter ICU stay, shorter hospital stay, and less transfusion rate. Another method to evaluate the quality of life is the Seattle Angina questionnaire. The SEQ score is another specific questionnaire. Is specialized. It is specialized to evaluate the coronary artery disease, which primarily reflect the relief of angina, the physical limitation, and the treatment satisfaction. As you can see in this figure, all these 5 domains of this SEQ score present the comparable result between the two groups throughout the 12 months follow-up. This result is also consistent with the other post-operative results, such as the comparable graft patency, comparable completeness of revascularization. So in summary, mixed cabbage could provide non-inferior midterm outcomes compared to the conventional sternotomy cabbage, including the comparable completeness of revascularization, satisfied graft patency, and similar MIS event. Besides, the mixed cabbage could also strengthen the short-term benefit. The mixed cabbage could significantly improve the quality of life and the relief of angina, and provide unfavorable perioperative outcomes and safety. Of course, there are many limitations of our study. The first one is the study is a single center study. As my introduction at the beginning, our center has always been lead the way in China and perform the high volume, the mixed cabbage. So our result is difficult to generalize. The second limitation is our study is only follow up to the 5 years, 10 years or 10 years, and 10 years follow up is needed. Besides, the study is a non-randomized design. A larger multi-center randomized controlled trial is needed. We all know the mixed trial led by Mark Zhou and colleagues in this summer in Seattle will present their results, which are very anticipated. So I'd like to acknowledge my colleagues who contribute to this research and this funding. Thank you.
Thank you very much. Really, Dr. Ding, it was a wonderful presentation with the outstanding scientific data that you shared with us. Thank you very much. The discussions will be at the end. So may I ask, David, are you ready? Your slides are ready?
Yes,
So Dr. Mishra, perhaps you can introduce Dr. David Taggart, please. Can you?
Professor Otto, you can continue because I am on the phone and
Okay,
I
okay.
read actually. So,
It's my really distinct pleasure to introduce Professor David Taggart, who is one of the pioneers of coronary surgery and also an expert scientist. I hope he will share his experience with CABG. And I think CABG, at the end of his talk, we will believe that CABG is still a gold standard in 2025. David, please.
Thank you. If I could have my slides, please. So I would like to start by thanking Dr. Otto and the Society for the invitation to take part in this meeting today. And it's great to see so many friendly faces. So thank you. So what I'm going to talk about today is why CABG does remain the gold standard in 2025. Next, please. Yeah, so clinically, my main conflict of interest is as a cardiac surgeon, and I do have some commercial interests, but none relevant to this presentation today. So when we talk about CABG versus PCI, it's always important to take account of 3 facts. If we look at the trials, are the trial patients typical of routine clinical practice? And usually the answer is no, because they tend to be patients with less severe disease that underestimates the benefit of CABG. Next, please. The second thing you must be aware of.
Recording in progress.
What is the duration of follow-up? And it must be a minimum of 5 years, and ideally it should be 10 years, as in the ART trial. And interestingly, later this year we'll be publishing the 15-year outcomes of the ART trial. But the importance of duration of follow-up is that the longer you follow up patients, the increasing advantage you have of bypass grafting. And the next thing to consider in the trials is, did the CABG patients get optimal medical therapy? And the answer is frequently no. And this is important because although CABG is already superior to PCI, those benefits would be even greater if CABG patients received optimal medical therapy. Next, please. And a general tip is, when you're reading text, either reviewing a paper or for your own edification, always look at the data and results before you look at the text, because the text will often have a very pro-PCI bias, as we see in FAME3 and the Excel trial. Next, please. So the key gold standard trial today is still the Syntax trial, now published more than 10 years ago. And this was very important because it's the only relative all-comer trial. Whereas I mentioned that all the previous trials of PCI versus CABG were very highly selected, Syntax attempted to be an all-comer trial. And it showed that at 5 years, a very significant advantage for CABG in terms of reduced mortality, cardiac death, myocardial infarction, and need for repeat revascularization, and no increase in the risk of stroke. The other thing Syntax showed us was that if we look at the severity of coronary disease, according to Syntax scores, in the lowest category, less than 23, there was a 1% survival of CABG at 5 years. But in the intermediate group, it was 7% at 5 years. In the higher risk group, 9% at 5 years, and accompanied by marked reductions in myocardial infarction and repeat revascularization. Next, please. So the now trial that we want to discuss is FAME3, published in the New England Journal in 2022. And this had tried to address two limitations of the Syntax trial, which were PCI was not FFR guided, and secondly, Syntax did not use the best, most modern drug-eluting stent. So in FAME3, 1,500 people were randomized to FFR-guided PCI using zotarolimumab stent. At 1 year, despite not wide non-inferiority limits, CABG was statistically significantly better, and PCI did not reach criteria for non-inferiority. And note that the primary endpoint was a composite of death, MI, stroke, and repeat revascularization. Next, please. But if you look at the 3-year outcomes of this trial, what then happened was the primary endpoint was changed. Repeat revascularization was removed, and this therefore tried to make PCI look non-inferior to CABG. But if you stuck to the primary endpoint of the 4 components, CABG still remains statistically significantly better. And one has to question, there were 40 authors in this paper. It was reviewed by statisticians, expert reviewers, and editors. And why did no one pick up on the fact that the primary endpoint had been changed? Because I've never seen that done before in any randomized trial. Next slide, please. If we look at patients with non-diabetes and compare drug-eluting stents and CABG, we can see that there is a marked and rapidly accelerating survival advantage of CABG as you go out past 5 years. And this is a paper written by 14 interventional cardiologists. Next slide, please. Next, thank you. If you look at patients with diabetes, go back one slide, please. If you go look at patients with diabetes, the best trial is the Freedom trial, and this showed a very significant and rapidly increasing survival benefit for CABG as patients pass out through 8 years. And the authors concluded, in patients with diabetes and multivessel disease, CABG leads to lower all-cause mortality than drug-eluting stents in long-term follow-up. And 2 things to note here, there was no category of Syntax score in which PCI was equivalent to CABG. And furthermore, these were patients with relatively low severity diabetes. So in clinical practice, our patients have much more advanced diabetes. Next slide, please. If you look at ischemic cardiomyopathy, then the gold standard trial is still the Stitch trial. It randomized over 1,200 patients to optimal medical therapy or to optimal medical therapy in CABG, and it showed after 5 years a survival advantage of CABG that continues to accelerate past 10 years. Next slide, please. Next slide, please. Thank you. And then if you look at this paper by Mark Grell's group, looking at almost 5,000 patients with impaired ventricular function undergoing PCI or CABG and matched for 30 baseline characteristics, you can see that CABG has a marked advantage for survival, reduction in MACE, myocardial infarction, repeat revascularization, and no difference in stroke out to 9 years. Next slide, please. Now, there has only been one randomized trial of PCI versus optimal medical therapy plus PCI in patients with ischemic LV dysfunction. 700 patients, ejection fraction below 35, followed out for almost 4 years. And in terms in this randomized trial of outcome, no difference in the primary outcome, secondary outcomes, death, myocardial infarction, hospitalization, or need for repeat revascularization. Next, please. So we can say conclusively there is no benefit of PCI in patients with ischemic LV dysfunction, unlike CABG. Next, thank you. So now I want to turn briefly to the EXCEL trial. This is now widely ignored by the cardiology community because it didn't provide the result that was anticipated. But EXCEL is the largest, most definitive trial of PCI versus CABG in left main. It did, however, have selected patients with mainly syntax scores below 33. So that's all about 1/3 of what we would see in routine clinical practice with left main. The randomization and enrollment were stopped early without being specified. The mean age of these patients was 66, so an anticipated life expectancy of 15 to 20 years. The primary outcome was a composite of death, MI, stroke, but not repeat revascularization. And the authors used a new biochemical definition of myocardial infarction, but did not include the widely used universal definition of MI. Oxford was the second largest recruiting centre in the world, and both the cardiologists and the surgeons at Oxford were very committed to trying answering this important question. Next slide, please. At 5 years, however, there was a very clear survival advantage for CABG, which was rapidly increasing. So even in these relatively low severity left main, there was already over a 3% survival advantage. But if you look at the Kaplan-Meier curves, you can see that they're accelerating, suggesting that with further follow-up, the CABG patients would do better. Next slide, please. Next, please. So the initial review by the editor of New England Medicine said the finding of a higher mortality rate in one group than another in a clinical trial, unless the difference is clearly trivial, should receive central emphasis in the reporting of the results, and we would generally consider it important to include such information in the concluding statement in the final paragraph. So I agreed with this as one of the principal authors of this paper, but when the next, please. But when the paper was resubmitted, it simply said in patients with left main coronary artery disease of low or intermediate anatomical complexity, there was no significant difference between PCI and CABG with respect to the rate of the composite outcome at 5 years. I did not believe that's what the EXCEL trial showed, so I removed my name from the authorship of this paper. Next, please. Next, please. So if we look at this, this is what happened in terms of the myocardial infarction data. As I said, EXCEL used a new, untried biochemical definition of myocardial infarction. Go back one, please, which was highly in favor of PCI. But when you looked at the universal definition of myocardial infarction, it was heavily in favor of CABG. And had the universal definition been used, EXCEL would have been even more strongly positive in favor of bypass grafting. Next, please. And next. So what then happened was there was a very determined effort by the cardiology community to overturn the results of the EXCEL trial. What they did was 14 cardiology authors combined 4 older, weaker, non-powered studies of left main disease until that mortality benefit of CABG disappeared. But what was also amazing about this was the speed of submission and acceptance. So within 11 days, this study was submitted to the European Heart Journal. It was reviewed, sent for revision, resubmitted, and final acceptance in 11 days. Now, that's just about a world record. And my advice to all authors is submit your paper to the European Heart Journal and say you want everything agreed within 11 days and see what kind of response you get. Next, please. So this is a very important slide. I've been showing it for almost 20 years and it's barely changed. But what is often not appreciated is why there is a persisting survival benefit of CABG over PCI. The first reason is CABG is mainly located proximally in the coronary circulation. And therefore, if you place bypass grafts to the mid-vessel, you not only deal with the proximal lesion, but you add protection over the longer term. PCI only deals with suitable localized proximal lesions, but has no benefit over the longer term. Second, please. A second fundamental difference is that the internal mammary artery elutes nitric oxide into the coronary circulation. This was shown in the New England Journal over 3 decades ago, and that nitric oxide serves to reduce the development of further disease. In contrast, drug-eluting stents impair re-endothelialization, cause downstream endothelial dysfunction, and create a prothrombotic environment. Third, next please. The third difference is that for most patients, PCI means incomplete revascularization, and this has been repeatedly shown to correlate with subsequent mortality and morbidity. Next, please. So if you understand these 3 fundamental differences between CABG and PCI, you can understand why, despite the ever-increasing technological advances of stents, they do not offer the same mortality benefit as bypass grafting over the longer term. Next, please. So what do we do in clinical practice? This is the 2018 EACTS guidelines. 2/3 of patients with left main disease have syntax scores above 33. They have a class 1A indication for CABG, class 3 for PCI. And if you look at 3-vessel disease without diabetes, 80% of patients have syntax scores above 22. Class 1A indication for CABG, class 3 again for PCI. Those benefits are magnified in patients with diabetes, and I would argue that CABG results would be even better if there was use of more arterial grafts and optimization of medical therapy. Next, please. However, next, please, you have to use your common sense. If you look at a patient, you need to look at the whole clinical picture and not simply the nature of the coronary artery disease. So old, frail, sick patients should not get CABG, but CABG is the preferred revascularization strategy in multi-vessel disease, especially in diabetes and impaired ventricular function. Next, please. But in 2021 were these new ACC/AHA guidelines, which significantly downgraded coronary bypass grafting for CABG from 1 to 2B. This was largely based on the ischemia trial, which wasn't a trial of PCI versus CABG, and it ignored that enormous body of existing data, which I've already pointed out to you. Accordingly, these new guidelines were rejected by every society of cardiology worldwide. Next, please. And I would argue that these guidelines have been very dangerous for patients, because to non-experts who would not understand all the evidence, this means that patients will be denied access to the option of CABG in view of these very fundamentally erroneous guidelines. Next, please. The guidelines were then upgraded in 2023 by the ACC/AHA. They've now re-promoted CABG. These guidelines were written by cardiologists, pharmacists, lipidologists, nurses, lay members, but notice, no surgeons. And you don't need surgeons on guidelines about CABG, because what do surgeons know about CABG? Next, please. I'm going to end up by recommending this book. This is a book edited by John Puskas, 72 chapters covering every aspect of pre, intraoperative, and post-operative management of patients. And then very final slide, please. And I would recommend to all who are genuinely interested in coronary artery surgery as a super specialty of adult cardiac surgery to consider joining the International Society for Coronary Artery Surgery. And the 11th International Coronary Congress meeting will be in New York, December the 4th to December the 7th. So for some of the excellent presentations that we've already heard today and that we will hear, please consider submitting an abstract for presentation to that meeting. On that point, I'm going to conclude my talk. I'd like to thank the organizers again for the opportunity and privilege of taking part in this meeting, and you, the rest of the audience, for your attention. Thank you.
Thank you very much, David. Really, it was an outstanding presentation, and I hope some cardiologists would follow this session as well, because the reality is vice versa, that the PCI is not always the solution, obviously. Thank you very much for this perfect presentation. The discussions will be at the end. So, Yugal, are you ready to introduce one of our faculty?
Yeah, I will, please.
We couldn't get in touch with Teresa yet. Probably it was too early in Canada.
Hello, I'm here.
Oh,
Hello.
are you here, Teresa?
Yes, I am here.
We are calling you in the last 20 minutes for many times. Oh, okay. Thank you very much for being us, Teresa.
Thank you.
So I hope from long distance you can thank you very much to share some time with us. Yugal is with Yugal Mishra is our co-chairman. Would you like to say something, Dr. Yugal Mishra?
Yeah. Welcome, Teresa. I think we are very excited to hear your views on coronary artery surgery. She is a board certified, both Canadian board and US board certified surgeon, and practicing the cardiac surgery since long time. We have numerous meetings where we witnessed this presentation. I'm sure that she is going to do a great justice for this meeting. Thank you. Over to Dr. Teresa, please.
I have to share, don't I? Let's just see. You can request, send request. Okay. Sorry, I'm trying to share.
Sure.
Multiple presentations can share. Is somebody on it? Looks like it might be.
There is one green button at the baseline.
Yeah, here we go. Okay, now what do I do? This one, and share this one.
Yeah,
okay.
It's coming.
What is this?
Great.
What is this? I don't need that. I don't need that. I need this.
Yeah.
There we go. Okay. All right. Perfect.
Perfect.
Good evening, morning, afternoon, dear colleagues, wherever you are. It is my great honor and pleasure to discuss, the role of bilateral internal thoracic artery in coronary surgery. My arterial grafting experience includes 30% BEMA in the first 15 years of practice. Sorry, my voice is going. I haven't even started. And then for the last 20 years, 78% BEMA. These are my disclosures. First, I would like to make a comparison with the ubiquitous saphenous vein graft. Why are vein grafts not as good? They were never meant to be arteries. Some last 30 years, but most don't. Common sense. The blood pressure leg veins is 60 over 25 millimeters mercury. Blood pressure in arteries is 120 over 80. Why are IMA grafts so good? Because God made them that way. They are a drug-eluting conduit. Prostacyclin and nitroxy comes from them. Alfieri said this in an editorial in 2007. They're composed mainly of elastic fibers, and they have nutrition from the lumen with rich lymphatic drainage. They auto-regulate in response to demand and location. Vein graft patency has not changed in 15 to 20 years, despite improved medical management. Fitzgibbon's seminal 1996 paper on coronary artery bypass graft fate of 5,065 grafts over 25 years was used as an early comparison paper with 3 other later papers. Early vein graft occlusion occurs in 12%. 1-year occlusion rates are about double that, and at late follow-up, after 15 years, 50% of vein grafts are no more. Why do surgeons not use BlTA? BlTA takes longer, but we are no longer barber surgeons. We don't need to be so quick. There's reluctance to believe in the superiority of BlTA and over CMA. Technical challenges of 2IMAs certainly exist, and there is perceived conduit coronary flow mismatch. There is the risk of sternal wound infection. A word about BlTA in diabetic patients. It can be done. I refer to you this paper. By adding multiple preventive measures, deep sternal wound infection can almost be eliminated when performing BlTA. One has to be cautious in only one subgroup of diabetes, and that is women with BMI over 30. In the last 1,490 coronary surgeries, there were 2 deep sternal wound infection, or a rate of 0.13%. In this lovely article in the 2013 Annals of CT Surgery, the anatomic and physiological properties are diametrically opposed for IMAs and vein grafts. If you look, everything's few, many, few, etc. This is a post-mortem comparison by Otsuka of the IMA and saphenous vein of 3 patients who died 2 years, 6 years, and 12 years after their bypass surgery. Note the IMA and saphenous vein lumina. Some vein grafts do, however, last a long time, but not well. Here's a 6-year-old vein graft, not so good. Note that the distal is perfect. It is the conduit body that folds, and this patient had continued to smoke. We have all heard of prosthetic valve patient mismatch. What about conduit coronary mismatch? A huge vein on a little artery. How long will these grafts last? Quality of the conduit. The sad thing is that surgeons sometimes cut up and down both legs trying to find some useful vein instead of just going and using an artery. Came across this pamphlet in a pharmacy. It states that 55% of women with 2 or more pregnancies develop varicose veins. How many women have only 1 child? Maybe this is one reason women do not fare as well. The ART trial, Professor Taggart embarked on a huge project randomizing single versus bilateral IMAs with 10-year follow-up. Why was there no difference between CMA and BlTA at 10 years? It was meant to be a trial of 1 IMA versus 2, but 40% of patients received other than intended due to crossover rates of CETA to BlTA, 4%, BlTA to CETA, 14%, CETA with radial artery graft, 22%. Therefore, there was essentially no difference in the tension to treat because both groups had essentially the same number of arterial conduits. There was seen a big difference in the as-treated group, significant improvement in both endpoints, all-cause mortality and a composite mortality MI and stroke. Experienced surgeons, greater than 58 cases, had much better results at 5 years at both endpoints, and the curves even started to diverge at 2 to 4 years, and even with intention to treat. Now a word about Roma trial by Mario Gaudino. This is an excellent editorial by Mario, after having finished enrollment of 4,375 patients to have 1 or more arterial grafts. However, I would like to say that Professor Taggart is responsible for laying the groundwork for Roma with ART by unmasking 1, how few surgeons actually did BlTA in their everyday practice, and 2, if they did not feel comfortable enough to enroll BlTA in a randomized controlled trial. This slide lists large contemporary coronary surgery trials. Roma is the 2nd largest after coronary. By this slide, one can see how ART influenced the plan of this trial. Without ART, these key differences may not have come to light until the trial was well underway. Now, I was asked multiple times by several people to join Roma, but one aspect that did not allow me to do this was the age of 70 years or younger. Early in my practice, I started with BlTA under the age of 60, and then when seeing patients return with failed grafts in their 70s, increased the age of 70, and this happened with every increase in age until by 2003, I was convinced, among other reasons, that BlTA grafting was needed for all who could reasonably tolerate this. So I could not, in all conscience, say to a 57-year-old patient, I do not know whether 1 or 2 arteries will make a difference to you or not. This was especially after I defended my PhD arterial grafting in 2015 at Erasmus University, Rotterdam. Professor Ari Peter Kapitein was my promoter. The website listed brings one to the thesis online. These are the chapters, all the papers, and the link at the bottom is directly to the PDF of this book. So when one has spent the better part of using BIMA in the majority of patients for 27 years, studying results from all angles, for me, there was no longer equipoise. This is the Roma enrollment of the last patient, number 4375, on 14th of April, 2023. Hopefully, this study will once and for all put to rest arterial grafting, one versus more arteries. What do the guidelines say? 2A for initial graft. The radial is better than the saphenous vein with high-grade stenosis, and BIMA should be considered in those without a risk of infection. If one considers the age of 70 years as the age below which BIMA grafting can be performed, if the average age of patients in most series is 65 to 66 years, possibly 66 to 70% of coronary patients could be under the age of 70. And even if one did 50% of these patients under 70, this would be 34% BIMA. If one did 80%, it would be 56, which is much more than what we presently use. This graph plots BIMA in the last 3 decades, beginning in 1990 when Kouchoukos alerted us to the increased risk of sternal wound infection with BIMA. Then followed at least 10 studies suggesting BIMA benefit to a diabetic patient, and the only thing we remember is Kouchoukos. Others included BIMA in the elderly, over 70 years, in urgent emergent surgery, routine use, in dialysis patients, hello Keto, and patients with reduced ejection fraction, less than 30% and 30 to 50%, and finally, BIMA in women. Hevney and Moore's study of routine use of skeletonized IMAs was prescient in the year 2008. Particularly, 42.3% were over 70 and 34.2% were diabetic patients. When not to use the IMA? True cardiogenic shock, no need, there's an IMA from previous ORs, unless you're going to add a second. Unusable, fragile, self-destructing, and for female diabetics, BMI over 30. The harvest of the IMA can be pedicled, skeletonized with a copper tip as a dissector with no power, or skeletonized with harmonic scalpel, which is both quicker yet safe. This is the IMA harvested with a harmonic scalpel, pink, not bruised, plump, not in spasm. A word about Plavix. Plavix is your friend. Excuse me. Coronary surgery has changed greatly over the decades. We rarely operate on smokers. Smoking damages perfectly good, large coronary arteries. So now we operate on small, diffusely diseased arteries. Plavix will keep a patient out of trouble postoperatively, maybe for years, possibly for decades. These are the patient groups in whom I use Plavix: active smokers, after endarterectomy, post-STEMI and STEMI, for off-pump, for diffuse disease, for complex anastomoses such as carving an ellipse of calcium from the coronary to enable grafting, and intentional purse stringing after endarterectomy has enlarged the native coronary orifice. Plavix is used 6 months to a year, depending. In some patients, I continue it for life. If it is not tolerated because of bad bruising, I reduce the dose to 3 times a week, Monday, Wednesday, Friday, with good tolerance. You can see I just about use Plavix on everybody. Further thoughts. There are 3 levels of awareness of cardiac surgical expertise. Surgeons are acutely aware of their immediate results. Cardiologists treating these patients, patients themselves. Cardiologists have known for years. Raphael Moore of Tel Aviv told me once that if any of his surgeons did not use BIMA, referrals would stop. Cardiologists see the untreatable vein graft disease, the hesitancy to operate on patients with a single patent Lima to LAD grafts, and the disabling chronic angina. Occluded vein grafts may not kill the patient, but they certainly kill quality of life. Cardiologists know what it is to have arterial grafts last decades. They follow our patients for this long. We surgeons rarely do. And patients are surfing the net and will question you about arterial grafts. Mine do. Here is an example of some Lima grafts. The first is a sequential Lima to diagonal LAD. The second is a composite Lima to LAD with a composite of the Lima itself to the marginal. The radial could not be used because the patient was on dialysis, and the Lima was used for the PDA. An in situ Lima to marginal through the coronary sinus. and in situ renal to PDA, it can be done. One of my younger patients was 29 years old, needed 4 grafts, and was also 14 weeks pregnant at the time of her surgery. She said to me in a letter, "Doctors always question the scar on my wrist and are astounded to hear that you used arteries in my heart. It makes only sense." Having coronary disease is like the specter of death hanging over you all of your life. By using IMAs and radials, one reduces this fear in patients. What would you prefer to have in your loved ones or yourself? Summaries. There are 7. Technical summary. In order to perform BEMA routinely, one needs to do routinely the things that honor and protect the IMA. Harvest the IMA the best way you know how. The anastomosis must be good enough to last decades. Plavix has enabled challenging grafting. Protect the devascularized sternum by adding multiple protective layers against infection. Review your work with transit time flow and echocardial ultrasound. Be patient, meticulous, and methodical, and be prepared to no longer be considered the fast surgeon. Successful arterial grafting, this is the surgeon summary, depends on the mindset of the surgeon. The mindset is dependent on mentors, training, and cardiological support. Arterial grafting can be used in all patient subgroups with safety and attention to detail. It is not just for some, but for all. The philosophy summary: coronary surgery has come a long way since days when we only used one, and endarterectomy mandated a vein graft. Low ejection fraction also mandated only vein grafts. One can connect anything to anything with success if the connection is technically perfect. Blood flows any and every which way. Nature abhors a vacuum. Aristotle, 384 to 322 BC. Coronary disease is lifelong. Use of arterial grafts gives the closest to a cure possible. Interventionalists know that no stenting extent to date rivals the longevity of BEMA. Drug-eluting stents can now last 10 years and more and are rivaling, sacral vein grafts. So to keep your job, maybe do a few more arterial grafts. This paper was one of those fun to write of all my publications. It is quite tongue-in-cheek. And I remember seeing somewhere that it was the most read of all my writings. I'm terribly sorry. It was written for the Surgeon's Corner in an interventional cardiology journal, Edmonton, Neurointervention. So, wrong way. Arterial grafting can be done routinely, treats all patients with the best conduits available without prejudice, preference, or judgment. To date, there is no PCI option that competes with BEMA. It is no more just a CABG. And BEMA is possibly the most important thing a surgeon can do for coronary patients. An extra 20 minutes for an extra 20 years. Thank you. Let me show. There we go. I think we stopped share. Thank you. Sorry for the voice.
Congratulations. Yugal, are you here? Okay, I'll go on. Really, it was a wonderful talk, and philosophically also it was admirable. And extra 20 minutes for extra 20 years is a really important slogan that we have always to remember. Now, I think it is, Yugal, I couldn't see you. Perhaps you can introduce the following lecturer.
You go ahead. You go ahead, please. Go ahead.
Okay.
Okay.
Dr. Gao, Mingsen Gao, is the chief of coronary cardiac surgery in Beijing Anson Hospital. He is going to give us the lecture on how to harvest beta in thoracotomy, by thoracotomy. Dr. Gao. Yeah. Teresa, we will have the discussions at the end. If you give us another half an hour, we will be back with you.
Yeah, good day to all. I'm Gao Mingxin from the third ward of the Chronic Surgery Center at Beijing Anzhen Hospital. And I'm honored to share with you the how to harvest the bitter wound via thoracorectomy. And I will introduce the following three aspects. Total arterial coronary vascularization represents the future direction of the CABG surgery, and the election of the arterial conduits is important. The arterial conduits are categorized into three types: type 1 trunk artery, including the intermammary artery, and the inferior epigastric artery, and type 2 lip artery, including the radial artery and type 3 visual arteries. Type 2 and type 3 arterial conduits exhibit a higher reactivity to vasoconstrictor and are more prone to spasm compared to the type 1 artery conduit. In contrast to type 2 and type 3 conduits, type 1 artery conduits release greater amount of nitric oxide and possess higher level of vasodilatory factors, thereby demonstrating superior endothelial function. As a representative of type 1 artery conduit, the AIMER demonstrates excellent anti-spasmodic and endothelial protective properties, thus ensuring superior long-term patency rate of the graft. And more than 80% of the AIMER directly organized from the first segment of subclavian artery. It descends 1 to 2 centimeters lateral to the sternal margin, coursing deep to the upper 6 costal cartilage and the internal intercostal muscle, and superficial to the transversus stomatic muscle fascia. Its distal bifurcation terminates at the 6th intercostal space. One of its branches descends into the rectus sheath, where it divides into two terminal branches, the superior epigastric artery and the musculophrenic artery. The other branch crossed obliquely outward the 7th to 9th costal cartilage, reaching the inferior part of the pericardium and the diaphragm. The AIMER is accompanied by two veins. The internal diameter of the AIMER is approximately 2 to 3 millimeters, with a total length ranging from 15 to 26 centimeters, and the average length is 20 centimeters. Yeah, as shown in Figure A, at the level of the first intercostal space, the AIMER gives off the pericardiophrenic artery, which runs in association with the phrenic nerve. This branch provides the blood supply to three critical structures: the pericardium, the mediastinal pleurer, and the thymus. The company internal mammary vein covers into the subclavian vein, as described in Figure B. This vein is not only large in diameter, but also limited the length of AIMER. To obtain the adequate lung AIMER, it's necessary to completely remove the epicardiophrenic artery, the main trunk of the internal mammary vein, and the surrounding fat. Additionally, the AIMER gives off anterior intercostal branches and perforating branch as it courses inferior through the upper 6 intercostal space, supplying organs such as the sternum and breast. The tissue surrounding this segment of AIMER and vein are loose and easily dissected. Another anatomically complex location of the AIMER is its distal bifurcation, as shown in Figure C. At this position, the AIMER gives rise to the superior epigastric artery and the musculophrenic artery. The AIMER and the vein at this location are closely adhered to the sternum and buried with muscles, making them highly susceptible to be injured. Moreover, excessive opening the sternum with retractors can lead to bleeding of that position and extremely difficult to be controlled. After understanding the anatomic characters of EMA, we proceeded with its harvesting. Step 1, dissect the visceral plunger, freeing it to the edge of the internal mammary vein on the left side of the lemma, and make sure you can feel the position of the entire EMA. Step 2, along the edge of the internal mammary vein on the right side of the EMA, dissect the transverse thoracic muscle fascia to fully expose EMA. The most critical aspect of this step is the dissection of the pericardiophrenic artery and its accompanying internal mammary vein. This area contains a lot of fat, thymus, and some small vessels. Its anastomic character makes it easy to injure the EMA. Step 3. Begin the dissection from an area with loose tissue, typically at the third to fourth intercostal space. Then ligate the branches of EMA, descending down the bifurcation of the EMA and up to the first intercostal space, as illustrated in the figure 3. Hyperinization and transect the distal end of the EMA, spraying the EMA with diluted piperine, and wipe it in a warm normal saline gauze for 3 to 5 minutes to reduce the risk of spasm. This completed the harvest of lemma. The harvesting procedure for the rammer is the same with the lemma. It's important to note that whether use it as an in situ graft or sequential graft, the rammer should be harvested with sufficient lungs, and the proximal dissection of the rammer should extend into the first intercostal artery, and the distal dissection should reach to the bifurcation. Additionally, it's advisable to harvest the rammer using a skeletonized technique, which can fully utilize its lungs. Compared to the pedicle harvest method, the skeletonized technique can increase the length of the EMA by 3 to 4 centimeters, equivalent to the length required for an additional anastomic stoma. Furthermore, the rammer and its branches are generally large in diameter compared to the lemma and making the harvest process less challenging. The 2021 HA guidelines for coronary revascularization clearly state harvest the EMA using the skeletonization technique to reduce the risk of sternal wound complication. And the guideline particularly emphasize use skeletonized harvest for femur grafting. So I will share our experience in harvest femur. First, whenever possible, use the skeletonized technique for femur harvesting. This approach not only allows for the full utilization of the femur's lungs, but also reduces the risk of sternal wound infection. However, the skeletonized technique increases the difficulty and the time of procedure. Therefore, the rammer should at least be harvested using the skeletonized technique. Second, the transverse thoracic muscle fascia is a major limiting factor for the loss of EMA. We should fully dissect the transverse thoracic muscle fascia at the beginning of the procedure to increase the loss of EMA and to fully expose it before harvesting, thereby reducing the risk of injury. Third, we chose the voltage of 15 to 20 volts when harvesting the EMA. This setting minimizes the thermal injury to EMA, and even if accidental injury occurs, the EMA also keeps the structural integrity. And fourth, the distal transection position of the lemur can be determined based on the corresponding position of LAD. However, the rammer should be transect as far distal to the bifurcation as possible to ensure that its lungs. And fifth, there are two particular vulnerable positions during harvesting. The first is at the first and second intercostal arteries. There was a transfer where the transverse thoracic muscle fascia surrounding the ema has disappeared, and the artery is enveloped by a large amount of fat and stemous tissue, make it prone to be injured. Additionally, the intercostal artery branches at this location are large and prone to be bleeding. Another vulnerable position is at the distal bifurcation of the ema, where the artery and vein are closely adhered to the ribs, increasing the risk of dissection. And six, we chose the transect the distal end of the ema after fully dissecting the entire artery. This approach reduces the pressure in the artery and its branches, thereby minimizing the risk of dissection. And the seventh, as type 1 artery conduit, the ema is less prone to spasm. However, after harvesting the ema, we will spray pipervarin on its adventitia and wrap it with warm normal saline gauze to reduce the risk of spasm. And if artery dissection occurs during the harvesting, we will discard the artery and choose alternative grafts. However, if the dissection occurs on the both ends during the harvesting rammer, it can still be used after pruning according to the required lungs. And ninth, if the ema is only terminally injured by the electrotome, the decision to further use depends on its integrity of its structure. And 10th, the ema has a low incidence of atherosclerosis. Even if calcification occurs in ema, we still choose to use it. Although there is current no clinical research evidence to support this practice. 11th, severe stenosis of the subclavian artery, ema dissection, and hemodynamic instability are contraindication for bema harvesting. And finally, we use Y graft method for the coronary vascularization after harvest bema. Yeah. After harvesting the bema, we first measure the flow in both ema. Then the harvesting rammer is anastomosis to the lemur to form a Y graft, with the anastomosis is typically located 2 to 3 centimeters proximal to the first anastomosis site on the lemur, most commonly the diagonal branch. This is performed using an A-to-0 suture for end to side at most anastomosis. Sequentially, we completed the anastomosis between the lemur and LAD, or perform a side-to-side anastomosis between the lemur to the diagonal branch, with the sequential anastomosis for the lemur to the LAD. Finally, we completed the anastomosis between the rammer to the OM and the PDA. And the 2021 HA guidelines for coronary vascularization clearly state that the bema grafting should be performed by experienced operators to improve long-term cardiac outcomes. And after harvest the bema in situ anastomosis and Y-graft anastomosis can be chosen. Studies have shown that there's no significant difference in the occurrence of major adverse cardiovascular events at 10 years between the two anastomotic methods. Our cardiac center primarily use the Y-graft anastomosis methods for the coronary vascularization with favorable long-term outcomes, although further follow-up still needed. At the proportion of the BEMER utilization in cardiac center increases the operative mortality rate and the instance of sternal wounded infection have gradually decreased. It's evidence that although BEMER surgery has a long operation time and more complex operation techniques, it can still be recommended as an all arterial revascularization approach. We have always believed that
Can you
BEMER
repeat, please?
it's not only a graft conduit for improving myocardial ischemia, but also a means to improve the physiological situation of the coronary artery tree. Yeah, thanks very much.
Thank you. Can you hear me?
Yeah, I can hear you.
Thank you. So I think now it's time to introduce my distinct, it's my distinct pleasure to introduce my dear friend, Dr. Kita Kikuchi from Japan, to give his talk on the place of minimally invasive coronary bypass surgery in 2025. Keita, please.
Okay, thank you very much for the kind introduction. Oh, I can't share my slide because okay. Now I can do it. Okay, thank you very much to Professor Otto kind introduction. I'm very honored to be here to take part of this webinar with great friends. So today my task is to present where are we in mixed CABG in 2025. So this is background. If you look at the less invasive CABG, we have a lot kind of options, mid-cap and rat CABG, T-cap, TC-rat, and mixed CABG. We have this kind of 5 options for less invasive CABG so far. And as you know, the mid-cap is basically a single bypass surgery using LITA and grafted to LAD, which is reported by Professor Carfole in 1996. At that time, we used this kind of retractor and this kind of skin incision with a small window bypass surgery. And this is robotic assisted coronary artery surgery. So it is usually harvesting theta or beta using Da Vinci system, and do Rita LAD plus hybrid coronary revascularization or multivessel mixed CABG. And this is total endoscopic coronary artery bypass surgery, so-called TCAP. This is actually this slide from Professor Sambarki. He does a total endoscopic bypass surgery, Rita to LAD and Rita to OM using only Da Vinci system. Amazing procedure. And this is TCLAT procedure by Babriak, called total coronary revascularization by left anterior thoracotomy. And he does complete revascularization under aortic cross clamp with quadriplegia and using LITA plus vein graft or radial artery. And this is mixed CABG. Actually, op-cap by a small left thoracotomy under direct vision. So I would like to share, explain mixed CABG. based on our result. So this is the first report of mixed cabbage, a report in 2009, published by Dr. Joe Magging and Mark Well. They're my good friend, and it was excellent result. And this is our surgical field of mixed cabbage. So usually we use this kind of retractor, and which is retracted using this kind of retractor, and make a good surgical field beneath the sternum. So what is the difference between mid-cap, recent mid-cap and mixed cabbage? This is different between skin incision between mid-cap and mixed cabbage. Mid-cap is more medially, and the mixed cabbage skin incision is more lateral. And the different what we can do is incision and IT harvesting. In mid-cap, a bit limitation and the length issue, but mixed cabbage we can see all mammary artery very well. And the retail harvesting in mid-cap layer, and mixed cabbage, yes, we do. And surgical feed, actually almost only LED in mid-cap, and the mixed cabbage, we can access to all territory. The bypass number is in mid-cap 1 to 2, and mixed cabbage, in our experience, 1 to 6. And proximal anastomosis is feasible in mixed cabbage to ascending aorta. And we report our tips how to disperse the heart using this kind of starfish, armless starfish in 2015 innovation. And these are mixed cabbage papers written up to about 2015, and not many, but we report 2 articles. So at that time, advantage of mixed cabbage was a shorter hospital stay after surgery, early return to normal activity, but no deep sternal wound infection, even a very severe diabetic patient, and reduce blood transfusion and increase patient satisfaction. However, we need to get the long-term prognosis. So BlTA should be used in mixed cabbage. Luckily, I visited London, Bob Keir and Macwell in 2014, and I did hands-on using a cadaver. Then I recognize we can access to the right mammary artery via this small thoracotomy. And at the time, I used a long shaft harmonic scalpel to access the right mammary artery with a pot. So I recognize even in mixed cabbage, we can access to the right mammary artery in 2014. After going back to Japan, I started to use the bilateral mammary artery in mixed cabbage and published a paper in 2015 in Annals. And we also published some paper in how to access to the ascending aorta by left thoracotomy in innovation. So these are our results of 6 bypass in mixed cabbage and 12 bypass mixed cabbage. Actually, these are almost same graft configuration compared to usual bypass surgery. So at the time, we compare theta and beta in mixed cabbage, and we conclude that beta can be safely harvested in a reproducible manner under direct vision by a small left thoracotomy. The potential advantage of mixed minimally invasive CABG using beta include a long-term survival benefit conferred by beta graft and elimination of the risk of sternal wound infection. So far, at the time, article of mixed cabbage using beta was 4 in 2016. Then we also start to use RGA in mixed cabbage. We reported the result. And this is our recent paper, minimally invasive coronary artery bypass grafting with ultrasonically skeletonized internal thoracic artery. We love to use harmonic scalpel even in mixed cabbage. We use 32 centimeter long shot harmonic scalpel, and in this result, analytic manner was done in 57%, and total arterial revascularization was done in 50%. And we use Rita, and radial artery and GA in this series. So this technique will help optimize mixed cabbage using the in situ beta with its associated benefit and without invasiveness and related complications of median stenotomy. So we think this is a good result, what we expect. And we also report how to use RGA in mixed cabbage. We published this paper last year in JTCBS Techniques. So we use harmonic, even RGA, we use harmonic scalpel, scissor shape harmonic scalpel, like this. And I'd like to share our video how to take down bilateral mammary artery and RGA together. Then I start harvesting bilateral mammary artery by a small less thoracotomy. Then our colleague start to harvest RGA using harmonic scissor time harmonic scalpel together. So when our surgeon take down the distal RGA, I take down Rita first. And after harvesting distal side of GA, I put a long shaft, this kind of burr, because I want to displace the right lung for the access to the right mammary artery. So I put this burr from the left side of the abdominal incision. Then our colleague can take down the proximal side of RGA. And after giving the heparin, we cut the RGA and bilateral mammary artery. This is the length of RGA. Now you can see the very good size of GA. So we make 6 centimeters more incision around the subxygoid. Then now we cut diaphragm like an inverted L shape and introduce RGA into the pericardium. Now we can see RGA like this. Very nice RGA. So I would like to share our mixed cabbage using bilateral mammary artery and GA. Now I take down bilateral mammary artery using long shaft harmonic scalpel, and our colleague take down RGA using shear scissor type harmonic scalpel. So this is right mammary artery harvesting. And introduce, I check the length of RIMA to the LAD and introduce RGA into the pericardium. The length of RGA is very good. And I put 3 deep pericardial sutures to disperse heart for the distal anastomosis. And this patient had a total occluded RCA. So I did GA to PDA anastomosis first. I love to use shunt tube for this anastomosis. And this is GA. The diameter was 2.5 millimeter. So even by small laparotomy and small incision on the abdomen, we can use RGA in mixed cabbage. And this Rima, I did a Rima to LAD anastomosis and Lima to this OM anastomosis. So this patient got the 3 bypass in situ arterial graft without touching on ascending aorta. So this is our result. Average this using RGA in mixed cabbage. Average this number was 3.2, and no touch technique, aortic no touch technique was done in 100%. Total arterial revascularization was achieved in 94%, and complete revascularization was achieved in 99%. And the inflow or triple inflow was in 73%. And actually, RGA was used for the RCA. So this is hospital, no mortality, but unfortunately, we have 3 strokes because of plaque rupture. But we don't touch ascending aorta. So even we don't touch ascending aorta, this can be happen. So this is our result of 4 bypass using beta radial artery and RGA. And we also start to use no-touch vein graft using EBH technique. Our colleague, Dr. Yoshino, reported in the result in innovation. And we also report the how to make a proximal anastomosis via right and second intercostal space using heart string. Like we open the right second intercostal space like direct the TABI and put a small wound restructure into the pericardium like this. And so now you can see ascending out very clearly and very shallow. The position is very shallow. You can touch ascending out very easily. Only 3 centimeters from the skin incision. Now I use heart spring for proximals. Like this. This is actually this access is very easy for all surgeons to make proximal anastomosis on the ascending aorta, like using op cap. And we also do appendage resection and pulmonary vein isolation on minimally invasive mixed cabbage. This is the result. We did a 3 bypass, sorry, 3 bypass for this patient with sorry, a middle doesn't move. With endoscopic PB isolation and left atrial appendage resection. So now I have many useful methods in mixed cabbage, multiple survival grafting, proximal anastomosis on the ascending aorta, off-pump analytic manner, beta RGA radial artery, no-touch substance vein graft can be used, total and multi-arterial grafting, concomitant surgery, PB isolation, left atrial appendage resection, TABI, and valve surgery as well. So this is our publications. So this is our indication of mixed cabbage. And this is strategy of cabbage. So we try to do mixed cabbage for all patients as a standard, but we have contraindication of mixed cabbage. So this is our strategy of mixed cabbage, complete revascularization, multi-arterial bypass grafting based on beta 1 improper area, and atraumatic surgery of palm analytic no-touch EBH. And impaired CABG for a poor EF patient. Recently, we start to use impaler in mixed CABG for poor EF patient less than 30%. So long-term durability, Magwell, Ottawa University report good result of mixed CABG. Survival at 12 years was 82%, and MACE-free survival at 12 years was 76%. And now we finish the MIST randomized control trial that year. So Mark is going to present the result of MIST trial in WATS this May. So this is my conclusion. This is what mixed CABG is today. In today's mixed CABG, it is a procedure that can be performed with surgical plan, graft strategy with long-term prognosis, similar to that of previous CABGs. In the future, it is important how to make this procedure easier so that more cardiac surgeons can perform this procedure. Thank you for your attention. Thank you very much. Thank you very much.
Thank you, Keita. Thank you very much for your excellent lecture. And you have overviewed your own experience and all the minimal invasive cardiac surgery for coronary bypass. Now we have distinct panelists. Probably you can start with asking questions.
Yeah. So thanks, Kita. In the middle of
Thank
the
you.
night, you are still with us. Great.
Thank you very much.
Always happy to listen whatever you are saying. And today, in 2025, my practice of coronary artery disease is exactly the way you are practicing, using multimodal approach and whatever best you can do for these patients. I'm really thankful, Dr. David Taggart, who had shown his persistent that coronary surgery is much better than PCI. And I think the evidence is emerging, and hopefully someday the cardiologists will realize, and for the betterment of our patients, they will start seeing the science, what the science says. Bilateral memory in octogenarian, the Teresa has shown that age is no bar for bilateral memory. That's great, and we are still conservative in our practice, but she has shown that she can use bilateral memory. Our trial, Dr. David Taggart doesn't, his conclusion is not too much towards the, the total arterial. But in some of the younger patients in our particularly in Asia, we are practicing that, and I'm sure in Japan also, in the same Turkey and rest of the world. And Chinese has shown that yes, we can practice that. With that, Dr. Otto, I have to leave to airport. So thanks to everybody.
Oh, really?
Thanks.
I thought you would ask some questions.
That's right.
Thank you very much. So then I can go with the other panelists. Dr. Ahmet Özkara is from Istanbul. Do you have any questions or comment on for the lectures? You are muted. You are muted. Can you? Okay.
Thank you very much for excellent presentations for our speakers. I want to ask Dr. Dink, did you have some problems if you prepare with thoracotomy with minimally invasive fashion, the right internal thoracic artery? Did you use free internal thoracic artery in some cases?
Dr. Ming is not with us. I cannot see him.
The first presentation.
Yeah, he left probably. Sylvia, Yeah, is Dr. Can you invite Dr. Ding again? Yeah. Hi, Dr. Ding. Have you heard the question?
Hello, I'm here.
Have you heard the question? Dr. Özkara has asked you a question.
Oh, sorry, I didn't get you.
Okay.
Can you repeat?
In minimal invasive bypass surgery, if you use the right internal thoracic artery, do you have in some cases problems, and then did you use free RIMA?
Oh, can I share my presentation for you?
So when you have a problem, have you use the RIMA as a free graft?
Yeah, yes. We in our study, the mixed cabbage, the RIMA rate is 18%. It's 18% in mixed cabbage.
Yeah. In my own experience, if we prepare the bilateral internal thoracic artery with robotic surgery, sometimes the right internal thoracic artery is not long enough. And if you do the same operation with sternotomy, you don't have any problem. But in minimally invasive operations, sometimes you have some problems because the heart is a little bit left side, and the length of the right internal thoracic artery is not enough. It's my own experience. And then we have to use the right internal thoracic artery with free fashion.
Perhaps Kita, you also take
yes.
down the right internal thoracic artery, and do you have, when you have any problem, do you use it as a free graft, or you
Yes.
have such a problem?
Sometimes it can be happen. In my cases, about 30 to 40%, the length of RIMA not enough to the RAD because of the disease RAD. And then I do RIMA to RAD anastomosis, and RIMA, right mammary artery, is extended using radial artery or no-touch vein graft to the circumflex or somewhere, PDA or somewhere. Yeah. This is the option. So we usually do contrast CT scan preoperatively, and we plan 3 options of the graft configuration before surgery.
While we came to discuss the RIMA problem, Kita, do you have sometimes to have to retract, take down the RIMA? Do you need, when you need retract the heart pericardium downward? Do you have some problems, or is it always easy to go to right internal mammary artery through over mediastinum, via mediastinum?
Basically, yes, almost yes, but it depends on the shape of the heart. Sometimes, especially horizontal heart, in horizontal heart, it's not so easy to use the right mammary artery as an in situ graft to the RAD. Then I do a Y composite or eye extension for RIMA. Yes.
Do you have some specific maneuvers to retract the heart and see the right internal thoracic artery better?
Basically not. I lift up the heart a little bit using girth, deep pericardial suture to near to access to the right mammary artery. So usually after open the pericardium, the heart rotates to the left into the left chest wall. So we need to replace the heart into the normal position. But it can be a cave surgery.
Yeah. Vadim,
Yeah.
do you have any question?
Yes, I have question. I thank you for the first of all for great presentation, but I should come back to real practice coronary surgery. I have question for Dr. Taggart. What do you think about the fate and future of guidelines of coronary revascularization? And second question, what do you think about real heart team?
So, two good and very relevant questions. In terms of the guidelines, I think the 2021 guidelines by ACC AHA, which did include some surgeons, got it very, very badly wrong, whereby every society of cardiac surgery in the world, every society rejected them. And then 2 years later, the ACC brought out revised guidelines, which re-upgraded coronary surgery, but written without any surgeons. So I think the way the ACC have behaved has been very detrimental to the concept of guidelines and what you can believe from them. In terms of the heart team, we are fortunate in Europe, I'm sorry, in the UK and Northern Europe, where we have very rigid heart teams. So, for instance, in the UK, any patient who needs coronary intervention in terms of PCI or CABG, all patients must be discussed unless it's 1 or 2 vessel coronary disease, not involving proximal LAD. Everything else gets discussed at a meeting. That meeting records who was present, both surgeons and cardiologists, a brief description, all done online electronically, of the coronary disease, any other significant comorbidities, and what the decision or recommendation of the heart team is. That's printed off and then put in the patient's case notes. So there's a medical legal electronic trail of what is being recommended to patients. So I know the same system in the UK happens in Northern European countries, but not South European countries. But in terms of if we're going to genuinely protect the best interests of patients, and we genuinely wish to do the right thing for patients, nobody would disagree to a heart team agreement.
Teresa, how the heart team thing is really working in Canada? Conceptually, it's not working in Southern Europe.
No way.
So how, if you go further north to Canada, how does it work?
Well, it's tough because most of the time it works very well, but you see patients who are high risk, and surgeons don't want to do them, so they are deferring to angioplasty, and I often disagree, and it's very tough. See, we're paid to do so many cases. High risk, you can do a low risk, or you can do a 150 high risk and 150 low risk, you get the same amount of pay. So surgeons tend to say that one's too high risk, we shouldn't do it. And we've done these patients, and I think this is wrong to have them go. So I'm not very happy with our heart team, to be quite honest. I think if you disagree with it, I had a patient who had was going for a kidney transplant, and they turned him down because he had, quotes, no symptoms. And the nephrologist went the back door to me and said, look, this guy, he's 57 years old. He had a high risk MPI, and I felt he needed surgery. And I booked him, and I had to represent at this rounds, and they said, we turned him down. And they said, he has no symptoms. I said, well, actually, I just saw him. He's now having breast angina. So, I mean, when you have to go to that sort of lengths, it depends on the people you're working with. David, you sound like you have a wonderful group to work with. And if you do, great. But if you don't, it can be problematic because human nature exists in all of us. That's my feeling.
Yes.
Go ahead, Ty. David, do you have any further comment? David?
Me?
Yeah, because I felt as if you are talking, so no?
No, what I was going to say was we pretty much follow the ESC EACS guidelines of 2018, and they very nicely define recommendations by the level of syntax score. So by and large in the UK, if you have multi-vessel disease and a syntax score above 22, especially if you also diabetes or impaired ventricular function, all of those patients would be offered CABG unless there is a contraindication. And likewise for patients with left main with syntax scores above 33, where the evidence is very much in favor. So most of our practitioners in the UK are pretty sensible, but it works also in favor of patients being offered surgery. Because 5 or 6 years ago, many patients in the UK would just get stenting without any discussion. Those cases have disappeared. And no cardiologist in the UK would now just stent patients unless it's been discussed by the heart team. So the rules are pretty clear.
I think,
George, do you have any question?
Yes, I have a few little question for everybody. First, I think the heart team is only for the cardiac surgery, for the surgery cases. The cardiologists usually are the gatekeeper, and in the majority of the cases, okay, they decide in the cardiac cath, the patient is laying, and they don't explain to him exactly what will be the future with the stenting, etc. Usually when we have tough cases and we are obliged to come to the conference and to present them. This is number one. I have two questions. Okay, first one.
Sorry, may I just come back to that on that point? Because this is what I was trying to say, and maybe I wasn't clear. In the UK, we are totally different. Cardiologists cannot do that. They've got to follow what are the agreed protocols. And so that's the big difference between the north of Europe and the south of Europe, that what you're describing used to happen in the UK, but it has gone.
Yep.
You're very lucky.
Second question is for you, David. Okay, we know today, and Teresa showed us the superiority of the full arterial revascularization. We still don't know why in the US this technique is not very frequent, and 80% of the surgeons in US don't practice a double mammary harvesting. Do you know why?
Well, it's actually 95% do not do double mammaries. But yeah, I think it's because essentially surgeons are just judged on short-term outcomes. There is no value in doing something that may benefit the patient over the longer term. And as we saw in the ART trial, now I did 412 patients in the ART trial, and my crossover rate from bilateral to single ITA grafts was 1.2%. Because the decision to do bilateral ITA grafts is made the day before the operation, not in an operating room. So in ART, the crossover rate overall from bilateral to single ITA grafts was 14%. And if you look at individual surgeons, the crossover rates varied from 0 to 100%. So what it showed you was that many surgeons, although claiming to have done 50 bilateral ITA grafts before the operation, clearly didn't have the appropriate experience. And as Teresa pointed out, that's something that Roma trial has taken much more seriously. They have much more rigid criteria to ensuring that the surgeons are appropriately trained and have sufficient expertise to do those operations. And it was these large crossovers, plus the use of the radial artery in the single ITA group in 22%, that's why we saw a neutral effect, I believe, in the ART trial. Whereas when you looked at as treated, what happened to the patients, there was a very strong survival benefit for those patients who actually got 2 or more arterial grafts.
Teresa, it's for you. I approach exactly the coronary disease like you. For the last 15 years, we use an all arterial and B harvesting for everybody. We have no limitation, obese patient, diabetic woman, and even we have a few cases of elderly patient. And we don't have a lot of fear of sternal wound infection, because on the last 2,200 cases, we get only 30 cases, 1.1% of sternal adhesion and not infection. But what your contraindication actually to the use of double harvesting?
Gosh, I think the only one I can really think of is and even a BMI of 30 in a woman who's diabetic. I've even done it by accident sometimes because I forgot to look. It's my own rule. But I think really obese, like a BMIs of 40, I wouldn't do it. But I mean, in somebody who didn't need them, or somebody who geez, I mean, I think if it's an elderly person and they're in their 80s and the radial is going to just be a good option, I will do that, but it's rare. I mean, 78% of my patients received bilateral mammary. So on those what's that, 22%, I think they only needed one bypass, but they only needed 2 bypasses, and I'd sort of do a sequential mammary to LED diagonal. So it's not very often. I can't even think, except for a very obese person, and maybe terrible morbidities, maybe bad lungs, very, very bad. You worry you have to do it off pump and what have you. But pretty much there's not very many that I don't do.
George, if I could
Just
there, please. Thanks. Sorry, Teresa. I actually think this age cutoff for bilateral ITA grafts is completely wrong. I think young patients get the benefit of longevity, and older patients get the benefit of a true no-touch aortic technique.
Yes, I totally agree with you.
I could send an 80-year-old patient to coronary bypass grafting and say there's a 1% chance they'll die. They say, yeah, I get it. It's a big operation. If a 3% chance of a significant stroke, they are terrified. They will much more readily accept the risk of death than being left alive with a stroke. But I very strongly believe, and have done for decades, that I think the cutoff for age with bilateral ITA grafts is wrong, because I think you're using them at different ages for different reasons.
Yeah,
Yes,
I totally agree.
exactly.
Totally agree. I have patients in their mid-90s that I did bypass the 2 mammaries in their 80s, like mid-80s, and they're still alive. It's just nothing, as you said this once, David, nobody goes home faster than an 82-year-old with a 2 mammary off pump, no touch aorta.
Last question to Kifta. Dr. Kifta, when you are harvesting your mammary by mini invasive, do you arrive to the subclavian orifice, origin of the EMA, or you stop before?
Yes, exactly. It's a good question. Usually, I take down bilateral mammary artery to the very proximal. I put the clip on the first intercostal lip branch, so almost to the subclavian artery. Yeah.
So you don't compromise the quality of harvesting, the length, you are doing it exactly like it's an open sternotomy.
I think so. Because I have used harmonic scalpel more than 25 years. So this is the reason why I can. Yeah. And one thing I have to say, I'm sorry, one thing I have an opinion because of the major articles written about off-bomb and on-bomb and a triad is actually based on young surgeon result. Because experienced surgeon doesn't do crossover ratio around 14% of the beta to theta, right? So even Ruby trial and other kind of bypass surgery, the result are based on immature surgeon result. This is a big issue because I think.
I think that mini invasive is the future of coronary surgery. Actually, the patient are reading on Facebook and Google, and they ask for it. And usually, is it possible to do it by a mini lateral thoracotomy? But my final word, I think, I remember a word of Alain Carpentier when we start in the 90s to make the off-pump surgery. In the European Society, I hear him saying minimal invasive, yes, mini surgery, no. I think we should never compromise our anastomose of the Lima LAD.
Basically, surgical quality first priority, top priority, even mixed cabbage.
Yeah. Thank you.
Yeah.
Professor Koray Ak from Istanbul, do you have any question?
Yeah, thank you for excellent presentations. I have actually two questions. First one is for Dr. Teresa. In the literature, we also believe in using advantage of using bilateral memory in coronary patients. But in the literature, it is shown by some authors that when you anastomose right internal memory to right coronary artery, the patency is a bit lower than the left side due to the competitive flow. What do you think about this issue? And my second question is for Dr. Keita. In our experience, pain is more common in after meat or mixed cap procedures, and it is usually, in my mind, it is a bit underestimated in the literature. What do you think about this issue? And do you use additional measures to control pain after your procedures?
Let's start with Teresa Kizer.
Okay, yes, I think there's several things with the REMA to the right coronary artery. We used to bypass when I started my training, 50% stenosis. You had to do a 50% stenosis, but there was no angioplasty then. Now there is, and now we know about competitive flow. So I now do not bypass a moderate, simple right coronary artery lesion. And if I do bypass, I always try to go to the PDA. Like if it's a serious bypass, a serious lesion, I go to the PDA. I think this is far better than the right. The right coronary artery is a solid core of calcium a lot of the time, and it's not healthy. It's not healthy. So I think the problem with REMA is that people can't make it reach to the PDA, but you can if you go extrapericardially and put a hole in the pericardium opposite the PDA or close to the PDA, and it goes extrapericardial and then makes the turn point at the level of the pericardium, and it goes true on to the PDA. And those I think do better. But also the right ventricle is a different animal. So it's got lower, it fills 50% to diastole, 50% asystole instead of 60-60-30, 70-30. So I'm a little cautious when I'm doing the right mammary. My right mammary most often goes to the circumflex, and I use the radial to the right, and it's a high stenosis. But a moderate stenosis, I will go to the cardiologist and say, look, I think this is not really worth putting a bypass on. It's only 60% stenosis. It's going to go down. And he goes, absolutely, if that is a problem, I can do that later with a stent. And you've got to remember that the majority of the highest rate of occlusion of arteries that we learn to live without, quotes, is the right coronary artery. So I don't get bent out of shape with the right coronary artery having to do that bypass. If it's a 50, 60 stenosis, if it's high grade, it gets the radial. And that's when you should bypass. If it's a CTO, perfect. What really drives me nuts is when people say, oh, I'm only going to do 2 bypasses. Just learn to live without that artery. It's like saying, well, I'm not going to give him a prosthetic right leg. He'll learn to live without with just 1 leg. You have to bypass CTOs. Anyway, I'll get off my soapbox. Thank you.
A quick comment here. So I certainly agree with Teresa. Don't use a right mammary to graft a right coronary artery unless it's completely occluded and you get a soft wall. But that's pretty unusual, as Teresa said. So normally you want to get it to the PDA. That I agree with. But in my experience, I've tried the things Teresa suggested, and I struck a right mammary to go to the PDA. And if you're going to try and do that, you end up having to take almost the full length of the right mammary. Now, we know from the work of Dr. He in China, he's published extensively that the last centimeter of both mammary arteries is much more prone to spasm than the main body. So we avoid doing that. So if we are going to use a right mammary to the PDA, I have found, this is my own experience, I found the only way I can do that comfortably is to extend the right mammary, either with a recycled piece of, it can be left mammary if you haven't used the full left mammary for the LED. It can be a piece of vein, as shown by Ki-Bong Kim. Veins attached to the mammaries do very, very well, presumably because of the lower shear stress and the exposure to nitric oxide, or a piece of radial artery. But I have definitely, in my experience, I don't find I can make even a skeletonized right mammary, which is what we do all the time. I don't feel or find I can get those in most cases to go comfortably to a PDA. But that's my experience.
Keita, can you?
Yes. Okay, thank you.
Yeah, can you respond to the Dr. Ock's question?
The pain control in mixed CABG is really important. And we do multimodal pain control. So we give pregabalin preoperatively and postoperatively, and also we give NSAID after surgery, and we do paravertebral blockage. Actually, anesthesiologist does paravertebral blockage for all patients. So it actually this pain control method works really well after surgery.
Thank you. Now, Dr. Basil Al-Zabkan is from United Arab Emirates, so Dubai. So do you have any question, Basil?
Yeah, I have one comment. Usually I was used to do Bima Richa when I was in Germany because of the quality of patient there. Now when I moved to the Gulf state, we have a lot of diabetic patients. As we can see roughly 8/10, they have diabetes uncontrolled. No? And I face the problem, the high incidence of pedestrianitis. Though I changed my habits completely, I'm using just only for those kind of patients, still they are young patients, below 40 years old sometimes, just Rima and radialis artery. So my comments and the speaker, especially on Dr. Teresa, that using the radialis artery, what I use usually routinely for my patient compared to the Rima, it is superior to this artery, or is it the same outcome? Because it was a lot of discussion about this one. Of course, using radius artery, you have to be considered the tight lesion. You cannot do it if the lesion below 80 or 85%.
No, I totally agree. That is the commonest reason I think why I only use one mammary is a diabetic, because the radial, most of the lesions are high, most of our patients, fortunately. But no, I totally agree. it's still, it was only, we did 1,001 cases, and I looked in it, and at one point I realized that I hadn't had a deep sternal wound infection for 2 years. It was back in 2004. And I thought, how can that be? Because I had 3% rate because I was doing so many double mammaries. And I had added multiple, I didn't have a chance to show this in the talk, but it's published. It's called Towards Zero. And it really, if you add multiple layers of prevention, you can really, really cut down your risk. I mean, I've never used bone wax. I use vancomycin paste. You take a little bit of 2 grams of vancomycin. Do you use vancomycin paste?
Yes,
Yes.
yes.
Okay, good. So, and there's so many things. I mean, skeletonization, it works, and off pump is better, although that wasn't really a thing. The other thing is just things like the prep, the skin prep. Is your skin prep what is it, betadine or chlorhexidine?
Betadine, no?
Betadine. Switch
Betadine.
to switch. You must switch.
Why?
Alcohol, chlorhexidine alcohol. First of all, alcohol defats the skin, so the chlorhexidine penetrates, and you have to put it on very carefully by the clock, 30 seconds over the wound. The nurses look at the clock and do this, and you don't rip it over on the bed. We didn't use it for decades because several patients were set on fire in the 1970s because you could pour it on like betadine, but it is not as bactericidal, and the chlorhexidine stays on for 24 hours for infection. So we did this in our whole center, and it just dropped the infection rate by 2/3. It was huge. So that is one I would really recommend, but you have to know how to apply it. It's very
But
important.
usually I don't have mediastinitis when I'm using just only vein or radialis artery and lima. The incidence is only high when I'm using just for those patients with uncontrolled diabetes. That is with the same betadine. Usually we don't have not more than 1 to 2% roughly.
Well, if you can get
second
hold of
point, these are
alcohol, it would really cut down your
Yes, but I got this point. Thank you for this one, for this advice. But about using the radialis artery, do you think it's more superior using rather than to use the rima?
Is it always possible? Are you asking, is it always possible to use the radial instead of the rima? I think it's just as good if it has a high stenosis. Yes.
I'm using it routinely.
Yeah,
yes.
no, that's great. If everybody did
Yes.
that, everybody would have 2 arterial grafts. And, I wrote another paper about complete revascularization. I found that if you use artery grafts, you don't have a problem. In other words, if you have an incomplete revascularization and you're using 2 arteries instead of 3 grafts, you still have the same results because it's maybe not total arterial that needs to be, it's that second arterial conduit that makes the difference for a patient. Can you, I mean, how many patients do we operate on with single vessel disease? In my practice, it's 7%. Okay. It's been a really troublesome rate. Whereas, so if you can do 2 arteries, you're laughing and the patient is happy. Good.
More than enough, no? Thank you.
It's muted. David, it's muted. You are muted.
David, you're muted.
Yourself, David.
So sorry about that, and thank you. Yeah, just a quick note that probably most people are aware of, but certainly the skeletonization technique, if you're using bilateral ITA grafts, is really important. We've published from the ART trial the incidence of 4 groups of patients: pedicled single ITA, skeletonized single ITA, and then pedicled and skeletonized bilateral ITAs. And the incidence of any kind of wound infection, including superficial, was 4 times higher in the bilateral ITA harvesting group. So skeletonizing, actually, you've got to learn to do that properly, because otherwise you end up with bruised, swollen looking conduits. But if you get your skeletonization technique correct, that is a very significant way of reducing sternal wound infections, and especially, we showed in the European Heart Journal, especially in patients with diabetes.
Yes.
I think with this, we need to conclude this session. We even exceed the time schedule. And I would like to thank to all lecturers and the panelists that contributed very well. And I'm very glad to have this distinct faculty members in this Asian Heart Society Cardiovascular Surgery Council webinar. Thank you very much, and see you again in next webinars. Bye-bye for now.
Bye-bye. Have a nice
Thank
day.
you very much. Bye-bye.
Lovely weekend. Bye-bye.
Recording stopped.